It enrages me that while hospital leadership makes, on average, 500,000 to 1 million a year in total compensation, the very patients who need their services can't afford it, and many go bankrupt over medical debt. Yet this chaos is attributed to physicians, whose total compensation doesn't even break 500,000 a year. Overall average compensation, 376,000 per year, a 3.6% increase over 2023. Primary care physicians about 281,000. Specialists around 398,000. Remember, physicians can't use the private jet or go to those wonderful resort-based conferences with hospital leadership because that's a kickback. There's approximately 6,200 hospital CEOs. There's approximately 1.1 million physicians. Nothing like a little minority control. And to further add insult to injury, it's minority control by the least impressive, effete, mindless group of numbskulls you've ever met in your life. It's obscene. It's maddening. And we just walk around and act like this is normal. And that is an excerpt from a post by my new colleague, Mr. Heath Veuleman, a healthcare administrator who started out in rural environments in Louisiana and now has transitioned into running his own consulting business. I ran into Heath on X because a lot of his posts were like cutting with a hot knife through a gigantic tub of lard, which is the American healthcare system. He cuts right to the heart of the problem and also offers solutions for the future based upon raw data from reliable organizations and basic math. So I'm excited to introduce you to Mr. Heath Veuleman from New Orleans, Louisiana. Let's get into it. Record. Welcome to Three Deeper Cuts podcast on a sunny Saturday, August 9th. Welcome to Mr. Heath Veuleman. How you doing, Heath?
Thanks for having me. It's hot in New Orleans.
Well, I'm honored that hot New Orleans. It's a great town. My buddy did his fellowships down there, and I've visited a handful of times. So are you from there or elsewhere in Louisiana?
I'm from the north part of the state originally, and I came down, it wasn't long after Katrina.
Okay. So closer to, I'm trying to think here.
Just south of Shreveport.
Shreveport, that's due east of Dallas.
Yes. The many people from Shreveport think that they are Dallas East. That's exactly right.
It essentially is deep woods. So, all right. So I found you through some mutuals on X, and the types of things that you were writing about were just hitting right on the money as far as what has been wrong with American healthcare over the last 30 years and what is the obvious solution that's standing right in front of us. And on your recent podcast with Anthony DiGiorgio, Anish Koka, and Dutch Rojas on the Doctor's Lounge, you summarize a lot of the points that you write about. I'll link to those when we publish this. But I want to get a better understanding of like where you grew up and how you got into this business in the first place.
I started out very young. I left my bachelor's program in an Edston pickup with 3 Remaid containers, and the hospital I was going to was a rural, and they provided a house. They provided a housekeeper. They were wonderful people. And that's how I started. I was thrown directly into it. My CEO on the board of the State Hospital Association. He was on committee of the American Hospital Association, a national and a state rural association. And so just proximity to her, I got to state in all of these kinds of things. And then she would send me 3 months out of the year to Louisiana. And so I got early of kind people who spent a lot of time with me and had a lot of failure. And it was just a great experience. But, I was 21 when I started. So real young.
Okay. So fresh out of college, and you got your degree in.
I have two bachelor's degrees. I have one in biology, one in psychology. I had this crazy number of hours, about like 170 hours. I went every love school, would stay in it if I could. And then when I started, wanted to go to medical school, and I had a problem with authority, and I got into a guy that I now know pretty well. We got into an argument during my interview at LSU New Orleans. At Tulane, it didn't go as well. And then LSU Shreveport, it did not go too well. And I was past the point of a PhD program. I wanted to do psychiatry. And so, and there was only one clinical PhD program in the entire state. And so it was just weird happenstance. And this hospital CEO that I'd worked with on some other things while I was in college offered me this job, and a mid-level management job at a hospital. I probably was definitely not qualified for it and way too young. But I started as a director in a hospital when I was 21, and I was over clinics. And that's kind of how I got started. And then entered
Okay.
grad school a year or two later.
So you graduate college, you're roughly 21 years old, and you get started in the healthcare administration business in the rural hospital environment. And so how long were you
Yes.
in that rural environment?
I was there for 5 years, and 5 years and a month, almost to the day. And the president of the Louisiana Hospital Association came up and said, if you do not leave this rural hospital, you are going to be a rural guy. And in healthcare, we have some very, very distinct circles kind of in the administrative world there. If you're an academic guy, you're in that academic space. If you're a community hospital or tertiary guy, you kind of float in those circles. The rural guys kind of float in those circles. So then there's even subsets of rurals like critical access hospitals and those kind of things. And you usually stay locked in an orbit, whatever orbit you're in. And so it really it resonated with me that it was time to make a change. And there had been a lot going on at the hospital. I had just completed a very, very large medical office building and some big clinics for physicians, and it offered an opportunity to go out on a very high note instead of a sour note. And so I left, and in the governor's office, the governor's health policy guy and I were kind of in a similar program at Tulane, and he was like, "You should do consulting. Have you thought about that? With all the AHA contacts and state hospital contacts you got through the South." And it made it sound very, very appealing. And I had a huge ego, and I started thinking, man, I'm just going to knock this out of the park. And it was a lot of ramen for 24 months. It was a very humbling experience. Started with one client, and it was a rough 24 months for sure.
Okay. So, but so you were trying to transition from these outlying clinics and hospitals to the big city. So was there a reason that you did freelance consulting instead of joining? I mean, New Orleans is a gigantic city. I'm sure there's, good positions for someone with your background there. Well, why did you deviate solo?
Yeah, I mean, to be honest, that first 5 years was rough. It was it was very rough for me. It was 18 and 20-hour days, 7 days a week. It was highly, highly political, and did not enjoy being behind the desk. It didn't fit my personality. I liked it when I was at the legislature or when I was visiting other hospitals or, showing some other hospitals how to do stuff. And, I wanted to have, when I went and interviewed, there were some very kind guys at health systems and in some tertiary care hospitals who wanted me to go work there. And I was like, I cannot be behind a desk again. And do I want to be this hospital CEO? Is really what I want to do. And I'd rather work with a variety of places and different provider types and modalities. And that's really what interested me. And so that's what I did. And it was great. I'd be in a children's hospital one day, I'd be in an academic medical center the next, or starting a physician-owned hospital or a behavioral health hospital. And the first part of my career did a lot of regulatory work. So a hospital would either be in a startup and would need a license, a certification, or accreditation, or they would get in a bind with a regulator, and we would come in and put oil in the water. And in the morning, I might be at a tertiary care hospital in the city, and then in the afternoon, I might be at a critical access hospital in the north part of the state. And then the next week, I'd be doing a project for NGM. Yes, and it was great. I really enjoyed it.
Okay. So it was 5 years of really scrappy work at those rural hospitals, long hours. It obviously suited your personality, at least the outreach part and uh, this legislative part. But you were more inclined to start your own consulting after that. So could you tell me like what happened over the next few years, like once you started to get your footing?
Yeah, absolutely. So when the bulk of my work would really be in regulatory compliance and survey and certification work. I did a lot of clinics on the front end. I've probably done, outside of people who've done exclusive rural health clinics, which is a specific type of federally licensed, certified, accredited clinic. I've done in Louisiana, I've done probably, 50 of those in this state alone. I've done over 200 across the nation, mostly for hospitals. Um, and, uh, and then I did a lot of provider-based clinics. These kind of came in waves. And then in 2018, I started working a lot for large multinational corporations. And then in 2020, I just did not understand how bad it was for physician-owned hospitals until I got a call from a law firm. And I remember the hotel I was sitting in when I got the call, and it was a state trying to close a rural hospital because they perceived them to be doing elective surgery during COVID. And I was a contrarian during COVID. I couldn't understand, in graduate school, I had 9 hours of epidemiology. So on the administrative track, that's a lot for non-clinicians. And, it was so bizarre what people were doing, what people were saying. And, 6 months before COVID, we were fighting with the American College of Surgeons to stop all of this masking. And, the American College of Surgeons had issues with AORN and APIC with some of the guidelines they were doing, running and doffing PPE. And so here we are 6 months later, and everybody's, wearing a mask into a restaurant, and then they take it off to eat and put the mask back on. And I couldn't square it. And so I was sidelined a lot from hospitals and health systems. And then the death knell was when I started working with physician-owned hospitals. I've kind of became, an anathema to American Hospital Association and large hospitals and health systems. They were not a fan of that.
Yeah, so I heard you on your last interview with colleagues on a podcast that you were essentially persona non grata in your previous or in your.
Yeah.
So was that primarily due to your pushing back on these blanket masking policies and these immunizing policies that didn't really make a whole lot of sense from an epidemiology?
Yeah, I couldn't understand. It was that. It was the vaccination requirements of staff. I remember when March 4th, 2020, reading a survey certification letter from CMS and then requesting, comments, but the comment period was very condensed. And having to send literature about, vaccinations and how we do this kind of stuff and how it was going to have a massive recoil effect, which it has. I'm sad. It brings me no joy to say that I was right about all of that from the get go. But it was bizarre to see physicians, particularly, these are the people who are trained. These are trained clinicians sidelined by people who, I think I had 32 hours, maybe 36 hours, in my master's program. And then I started a doctoral program, and I only took a couple classes there, compared to a physician who had 4 years of medical school on top of a bachelor's program and at least 3 years of residency, depending on the specialist you're talking to. And their care is being directed by some lappy who can't even spell epidemiology. And it was just so bizarre for me to watch. And I couldn't square it. And, there were some other things that didn't help. I'd worked a lot with some large multinational corporations before this, and I'd worked with some private equity and, um, you know, healthcare. There's a reason there's a hospital in every, drama or soap opera. We tend to eat our own, and people don't like to see other people do well. And so, I think there are some hospital CEOs who saw me doing well, and they were like, "No, that's not," they were looking for an opportunity to sideline me from that as well. And that's totally fine. But, it was just a very bizarre time.
Uh, Amen to that, brother. It was wild.
Yeah.
I would echo your sentiments. I was a fellow in Houston, right about so in 2020 during those first few waves of lockdown, and I was handcuffed. I had to keep my job. I mean, we had a little one. I couldn't afford to lose my source of income as a fellow, even though it wasn't, a big salary. But I was wondering the exact same things. People that I respected in this business were just kind of bending the knee. So I will ask you this, and because you start to see more and more physicians working for a corporate health system over the last 20 years, especially after the Affordable Care Act, that is just the mentality that physicians are kind of punished for pushing back, uh, basically thinking critically.
Well, I think to a degree, yeah, I look back, and it's just a philosophy I have in life. I look back at all adversity with gratitude. I'm grateful for that COVID experience because we would not be here today, without that experience. That what has happened in the past 60 months is directly related to the insanity, and people just there's a time social groups take much longer than individuals, and there's an old phrase in human behavior that, people are smart, or individuals are smart, but people are dumb, and groups behave very differently than individuals. And it's just because of how information diffuses in a social group. And so it took, this long to get here, but it has accelerated, what we're seeing in the system and kind of the end of this macro cycle. And so because of all of that insanity that's played out, it has really pushed the consumer to say, you know what, I think that I don't trust, a big health system to tell me when I can see a physician, how I can see a physician, and I have to pay double to see the physician, pay a technical component and a physician fee. And it started, making people ask some questions. And, one of the things we've always seen in hospitals and health systems is that consumers trust the physician. Doesn't matter how good your branding is. And if a physician gets stolen, quote unquote, across town, like here in New Orleans, there was a really kind of, famous, I guess is a term, it's relative, but a famous neurologist who, moved from an HCA to another system here in town. And, we all knew what was going to happen. She didn't. She was very, very worried that no patients would move with her. 90% of patient migration follows the physician, and hospitals and health systems know that. They do not follow the health system. So whenever you lose a high performer, someone that's integral to your hospital or your health system, it's a big deal to hospitals, because you lose that patient and you lose the downstream that comes with the patient. And so, um, you know, hospitals and health systems right now are in a very precarious situation. And the only reason that they continue to enjoy the benefits that they have is because the majority of physicians still believe there's somebody behind the curtain. The curtain has not been pulled back for everybody. Just like at Oz, the curtain gets pulled back, you realize, oh, this is a goober. This is nobody. I've been listening to this person. And these hospital administrators, they're very, very easy to squeeze. They're very easy, but physicians don't know that. And so, but we're starting to see it. We're starting to get a little critical mass here.
Well, I hope so. And that's why I really wanted to talk to you on here and get this message out. First of all, I totally agree with you. I mean, going back to the whole Gustave Le Bon, book on crowd psychology, crowd behave vastly different than individual.
Yes.
And there's a whole branch of, I mean, anybody working for a political action has studied this in detail, in their training, and they use that to manipulate crowds. They're no different. When you get a group of them together, first of all, as you well know, most physicians, especially from polar opposite specialties, they just don't get along.
Right.
They do the exact opposite of what they're supposed to. Like you put a room of a bunch of Marines in a room together, and find out a way to make each other stronger and just dominate. Physicians kind of do the opposite. And maybe that comes from the training culture, kind of the diva academia culture. I don't know, but we found ourselves in this position where we have a golden opportunity to work together and make the whole system better by transitioning more to a direct care system, a direct contracting system. Could you explain to the audience, residents and early career physicians, how specifically did the hospital industry destroy private practice?
That's a great question, and it's just like everything in life, it's multifactorial. So, if you start on the education component, education became prohibitively expensive, and students were coming out with $250,000, $300,000 worth of debt. And us on the hospital administration side, we liked that, because that meant we could offer you something you couldn't get anywhere else, which was loan repayment. And the American Hospital Association, the Federation, National Rural Health Association, all of these players work to keep you kind of chained, for lack of a better term. And, without going into education, because that's its own weird little industry and why the cost is so insane. But that's a driving factor in and of itself. The other kind of major component of this is this misnomer of work-life balance. And it's sold to physicians as though salaried life is easier. But that's just not true. And there's a lot of literature on kind of human satisfaction, human enjoyment, that entrepreneurs are more highly satisfied than people who clock in and clock out. However, there's this zeitgeist, and I think it's more of a macro cycle. And I'm a big cycle guy, I'm a big pattern guy, but I think that was just kind of the zeitgeist at the time, and that pushed people in. So you have all of these kind of factors that line up. And then, it's one of those situations where it is the boiling of the frog. You get in the bath, you just sit in there and the heat just gently turns up. And then you wake up one morning and you're in a goddamn hellscape, of did you clock in this morning? Did you complete all the charts and do this RVU? And, did you sign this off? And now it's 37 clicks to order a X-ray, and you can't, write this because it's not on the formulary. And, just kind of it's maddening, for physicians today who are salaried. I do think there are still some that like it, when they first get out, but after about 60 months, 72 months, you start, just, it sucks your will to live right out of you. And it's a slow burn.
And that's a key point right there, and it kind of ties into this concept of moral injury.
Yeah.
I mean, that's a little bit more advanced in terms of like the ethical problems at large organizations that you witness as a salaried. That you can't really say anything about it. You're financially covered.
Right.
It's just nothing. You have enough money saved up to live on for a few years before you start your own thing. But yeah, the quality and the autonomy that you expected maybe is not there. But you were lured in by this fantasy of work-life balance, and it's just a lie. And matter of fact, when I would finishing my fellowships, Heath and Methodist, they were just started to implement this policy of required badging in, like you had to swipe your badge to log your hours. It was ridiculous, man. And I refused to do it. I was just like, no, I got my paper pencil log. I'm not breaking duty hours. Here's my sheet. And I would just refuse to do it. And, I graduated and left. But, some of the younger residents, because I was already board certified pathologist at the time, but some of the younger, residents, they're just like, well, I don't want to rock the boat too much. Let me just bend the knee and start swiping in. But what that does is subconsciously you start viewing yourself as a shift worker, as an employee. You're not thinking of, owning your own practice one day. And I think that's by design. This 100%. They want you to get comfortable with that mindset.
That's exactly right. So, and they would hire people like me to come in and design. It is a psychological system, 100%, to keep physicians compliant. And the way we would sell that is through fear. So we'd sell that through Stark, anti-kickback. Do you want to be in an orange jumpsuit? We don't want to be in an orange jumpsuit. So this is all about compliance.
Could you elaborate on that Stark law concept and how it applies to what we're talking about?
So what they are trying to do, the way it's sold is that, your time sheet and how you allocate, an administrative expense versus a clinical expense, and how their time is kept. And, it's all of these things that are sold under the guise of Stark, which is not in the law at all. Not in the law at all. And so, the only people worse than a hospital administrator are healthcare lawyers. They are, with exception, they are almost, entirely dumb. These are attorneys you will not see in court, and they're just everywhere now because of how much money they make, because a hospital, all they do is get legal opinions. And so, it was absolutely used for compliance purposes. And the way we would talk about physicians around a board table is physicians are the cog in the wheel, and we have to have the cog in the wheel to produce the output, which is the patient. That is our widget. And we want this widget to circulate through our system. We want to have a referral loop, and we want all of these stops along our referral loop to maximize the revenue from the widget. But physicians are just a cog in a wheel. And, to the extent that we need more cheaper cogs, then look at what's happened to primary care. We've pushed primary care physicians. I don't know why anyone would go to school today to be a primary care physician when, you are on the same plane as an allied health professional, whether that be a nurse practitioner or a physician assistant. And I'm not against nurse practitioners.
That right there. Yeah. Yeah. That's a key point, Heath, is that what started as the concept, this actually started in the military.
Yes.
First PA school was invented. It was invented in the Army. I forget the guy's name. I'll paste it in the link, but it was designed to be a physician extender, and they would closely supervise. And we all know a handful of NPs and PAs that we would trust our own life with. I mean, some of them are they're very dedicated. They also know their lane. But something changed in the last 15, 20 years.
Well,
where there was kind of the mid-level lobby. I don't know if they paired up with the hospital lobby, but
yes,
but the over-reliance on mid-levels was, in my understanding, is pushed very aggressively by the hospital.
Yes.
Okay?
Yeah, they were paired.
The intention was not as a physician extender anymore. It was as a physician replacement.
Correct. That is correct. And again, it's math. Hospitals know the same thing that everybody knows, is that there are not enough physicians, and those seats have also been kept purposefully low. And at first, that was at physician direction to keep the seats fixed to where they were. But then other interests, such as hospitals and pharma, got involved to keep those seats artificially low. Now what we want is to keep a patient tethered to, right now it's mid-levels, but mid-levels are about to get the shock of their life because they're going to be replaced by AI. It's already being tested. And so there's legislation right now today in Congress for AI prescribing. And so, primary care, the 5 specialties of primary care are under a direct assault. And if you're, what I tell people all the time, I use a concierge physician. I use direct primary care. I have $0 invested in any equity. It doesn't behoove me at all to say use primary care. But if you're a patient today, you better find a primary care physician that you can trust, that is not employed by a health system. If you are a primary care physician, whether that's family medicine, internal medicine, pediatrics, OBGYN, or even general surgery, depending on your market, you need to start looking at, how do I migrate to direct primary care as soon as humanly possible? Because private equity knows that boomers are aging, and there are not enough physicians to take care of them. AI is needed at Amazon. It's needed at Walmart. Both of those companies are looking to push drugs. That is their big push. They wanted to get into 340B. They could not. And it's, that's the whole purpose of primary care today, is to kind of push these things out. And it's a mess. I mean, it's a real mess.
Could you just explain to maybe the junior resident what exactly is 340B?
Yeah, so 340B is a drug pricing program where a hospital is made whole by pharma through rebates. But a hospital is made more than whole on the pricing. So hospitals actually make money on every prescription that a physician writes or a mid-level writes in a provider-based clinic. And provider-based just means a department of. You have to be licensed as an entity of the hospital. So let's say, and some of these rules changed in 2015 and smartly, but did not do enough. And look, I'm contributed to this problem. I've done over 2,000 clinics in the United States, 100 at one hospital, 150 at another hospital. It's a major problem. It's where the hospitals will get a technical component. So like right now today, I think you get $37 in Louisiana for an EKG at some, if you're just in a normal clinic throughout the state. But if you're at a provider-based clinic, the reimbursement for an EKG is $141 for the
Well,
same exact test.
yeah.
And that's just the technical component. The patient is going to get a technical component, plus they're going to get a bill on the pro side. And so, this madness, we could create a lot of savings just on elimination of 340B, which is the drug rebate program, and where hospitals make significant, tens of millions of dollars. I mean, it's obscene the amount of money, but even more so on the provider base side, it is obscene what a hospital is charging as a technical component and getting back from the federal government. It really is.
Taking notes as you're writing this, as you're saying this. Uh, Everything that you just talked about for the last 10 minutes is the reason that I stepped away from primary care and retreated back to the lab. Because I just didn't, I mean, I was at California at the time. I was like, do I do a family medicine residency in the Navy, or do I just, I mean, I was ready to just take a knee and just find something else to do for a living. Now pathology, I have more of a symbiotic relationship, with other physicians. And I have a lot of, I have some space to kind of see things from a distance. AI, of course, is going to come to pathology and radiology as
Right.
well. A lot of us are welcoming it, for multiple reasons, because we know it's going to happen no matter what. But the gold standard for a tissue diagnosis of XYZ tumor is still going to require pathologists to calibrate the algorithm. And even in some entity, there's a lot of gray area. It's a subjective call based on objective criteria. So there's that. For those of us that have an interest in that sort of thing, absolutely, I want to be I want to be the one like helping to calibrate the machine that makes my life easier. And then the other thing is that there's not enough pathologists to do the work right. And this is going to get worse in the next 5 years.
Yeah.
We're just barely seeing the start of this, of the mass retirement. But there's going to be a dangerous shortage. And so there's some Scandinavian countries that are already doing a lot more telepathology and AI-driven pathology because there's nobody to do the work. And so
Well, and what you're going to see, and you can write this down. The way this kind of starts winding down is the siloing we used to talk about 20 years ago, and that we wanted to get away from. Like, for example, here in Louisiana, you would always hear, we had a charity system, and then we had a non-charity system, and we wanted to get away from that. And that wasn't just, it was a holdover in Louisiana for sure. And the rest of the United States had moved away from that, but that siloing is coming we're looping right back around to it. And what's going to happen is governmental payers are going to have mid-levels in AI, and other consumers are going to demand face-to-face physician, whether that is through telepresence or other things. And the writing is going to be on the wall that it's going to disclaim when your care is AI driven. And so that is coming probably within the next 36 to 48 months, that this siloing will occur as things continue to break down. And then there'll be this massive breakdown, and then there'll be a build back. And but that's the writing is on the wall. That's what's going to happen.
yeah. And so as you said, a lot of people don't know what's going on behind the curtain. And I'm witnessing this in my day-to-day life, where I see horrific mistakes happening because you have somebody who's not trained. They have 1/10 the training of a physician, and they're being asked to cover hundreds of patients that are complicated in the middle of the night, and mistakes happen.
Right.
I mean, not knowing what you're doing is highly dangerous and can be fatal, and it is fatal. And the public just doesn't know. There's a lot of stuff that obviously I can't really say in a public setting because I've signed non-disclosure agreements, but I see these themes happening not at one hospital, at all the hospitals because of this very thing. The over-reliance on mid-levels and uh, uh, unfortunately, I agree with you. It's going to have to get worse before it gets better. And the AI-driven care is going to be one subset of the population. And those people that do have the financial resources, they'll be able to pick and choose a concierge physician to manage their care. Otherwise, they're just stuck seeing somebody who doesn't know what they're.
That's exactly right. And we're seeing crisis. We are in a crisis right now in a non-physician discipline. We're in a crisis with nursing. And it is nurses who graduated from school between the year starting around 2010. They are of a different caliber and quality. Part of it is generational. Part of it is the educational programs. But it is really bad. And, nurses who today, I would say if they are, 37 years old, 36 years, I wish they had a label on their name badge. Because it's so rough, that is a group to avoid. If they are younger than about 36, then, it could be just the competence, basic competence level is very, very scary, which is another reason physician-led enterprises that the quality is better and the cost is lower because physicians handpick their nursing staff. It's a big, big deal. And then the second component, just like you said, is mid-level driven care. And we're at a crisis there as well. And then in the physician discipline, we are in a crisis today with anesthesia, and that is really private equity. And the payer's solution, the private equity buying all the anesthesia in the United States for all intents and purposes, was to push the professional component into the global of the hospital. And so now hospitals are having to eat anesthesia pro-fees to keep any anesthesia. And the anesthesiologists that are left, there's very few. There are very few anesthesiologists. It is almost, I think within 60 months, it'll be almost exclusively CRNA driven. And it is almost cost prohibitive for ambulatory surgery centers and for physician-owned hospitals because there is basically no pro fee on from the payer on anesthesia. It is wild in that market. And so we're at a crisis with nurses, mid-levels, and anesthesia.
So, all right. So to kind of shift frame a little bit, a lot of the stuff that you write about on X, it's not all pessimistic. In fact, a lot of your posts are fairly optimistic. Can you describe the renaissance of medicine that will happen over the next 20 to 30 years? What are the components of that?
Absolutely. So what's going to happen is the dislocation of capital. When the delta is too large and it is too dislocated, it collapses. You have to start back. These cycles are as old as time. And we're in the final stages of this cycle right now in healthcare. And what will happen is the physician and the patient will kind of be reunited. And there will be a few little things. The physicians won't be as paternalistic, and patients will be kind of transformed into consumers by other industries. That's not a bad thing. It's kind of a good thing for both. And so, as patients and physicians kind of come back together and that relationship is resuscitated, no pun intended, the system around it, including the financing, is going to drastically change. What we see with physicians today is in a physician-led enterprise, you would think that utilization would be higher. So, which that's, because it would just drive cash flow to them. But physicians by training are naturally conservative. So in physician-led enterprises, utilization is lower. And so the fragmentation that you hear policy people talk about, fragmentation does create duplication 100% of the time. That is true from a policy perspective. There's literature on that. But the reason everyone's always been curious, well, why don't we see that with physician-led enterprises? That's because they don't overutilize services. So if you get an MRI at, XYZ health system, but your spine surgeon is at XYZ physician-owned hospital, he says, just bring your films over. Or you just had labs within 30 days. Well, just bring those labs over. There's no need to reconsume that service. And so we don't see the fragmentation and the duplication within physician-led enterprises. We don't see overutilization. What's driving utilization today and overutilization, believe it or not, is the very thing that was claimed to be used to stop it. It was not. It was for hospitals, and that is work relative value units. When I induce you to say, okay, well, here's a 2.0 RBU and here's a 3.0 RBU or whatever in the scale, and I, as a manager, come to you and go over your RVUs, it is a natural inducement for you to produce. It's a natural inducement for you to utilize. And hospitals know that because they want the technical component of the utilization. So they're trying to induce your utilization with work relative value units. Excuse me. We don't see that in physician-led enterprises. We don't see that overutilization. So healthcare will be cheaper and it will be more efficient whenever you remove these third parties. And that's what will happen sooner rather than later.
Awesome. So what would be your advice to a current pre-med student to prepare for the future of medicine?
If you're a pre-med student today, you're going to be coming right into the new era. You're going to be getting out of residency in the new era. And so it's to think differently about how your practice pattern is going to look. And that some, nurse manager is not going to be controlling where you see patients, when you see patients, what your schedule looks like, what your service array looks like. You're going to be thinking about how do I provide care to this patient that they need in a place that is comfortable to them, and how do I deliver care that tethers the patient to me and is not reactive. So that transition is going to be happening at the same time. And I'm not just talking about peptides, and I'm not just talking about IV therapy. There's going to be this kind of new movement for people who are really, and these are going to be people that are 50 years younger. And as they age, they're going to see physicians as a health partner. How do I optimize my health? How do I optimize my longevity? And so your service array no longer is going to be 10 CPT codes that start with a 99. Your service array now is going to be designed for specific market segments that is really consumer driven. And so that makes a lot of physicians tense, but it actually, care is going to be better, and it's going to be better financially, both for the physician and for the consumer. Not going to be great for health systems and payers.
Yeah, I totally agree. Finding one's niche within healthcare and thinking, having these conversations much earlier in the game will be very advantageous.
Absolutely. And go in with some basic math. Let math be your guide here. Otherwise, you're going to get trapped in wives' tales and rumors and all this kind of stuff. There's 1.1 million physicians left in this country. Half of those are primary care. The other half is specialists, and that's rough. There's a little bit more on the primary care side, and the rest are specialists. About 38% of that number is aging out in the next 5 years. There are, that we know of, 400 million people living in this country. And somewhere in the neighborhood of 68% of those, you just round it up to 70% of those are workers. And businesses are coming to the same sense very quickly because their employees are bringing it to their attention that they need healthy workers, and not just physically healthy, but emotionally healthy, spiritually healthy, socially healthy, cognitively healthy workers to produce, or the widgets don't get produced. They're looking at absenteeism. They're looking at production as a whole. And so those two things, kind of the convergence of the consumer and business and industry, who pays, in some markets upwards of 75% of the total insurance burden in a healthcare marketplace, is going to drive a radically new type of relationship between the physician and the patient.
That's all. I'm really looking forward to that day. I also look forward to being able to contract directly with the clinicians that I serve.
Yes.
That I'm diagnosed for. I don't want to deal with one of these big payers.
Right.
I would rather just work it out as amongst professionals who have the same kind of end goal in mind. Is that if you keep the patient at the front of your decision making, that's good for your brain. That's good for your business. We all do well together, and the patient wins too, because they had choice, and that they can choose to leave someone if they're not upholding their end of the bargain.
That's exactly right. And patients are going to demand that. The consumer is going to demand that it be patient line. It's going to happen 100%.
I mean, I believe in the power of story, and I believe in the power of, like you said, math. People don't really. So first of all, the math isn't really talked about, and people don't understand what's really going on behind the curtain and what the incentives are. But I think that the more conversations that get released out into the ether, the more you're going to see consumers wake up and demand this, as they already are. Now, there is the viral story of the breast surgeon in Austin who was basically just advocating for her patients, her breast cancer patients, at scale. This has never been done before because the internet and the mass sharing of short-form videos had never existed. She's suffered because of it. I mean, I know she started a big GoFundMe account and offset some of the legal expenses to keep her clinic running. But for the working doc in the trenches that sees what's going on behind the curtain, and wants to get these stories out there, what would you advise them, and how would you caution them?
You know what? I would point out United Healthcare stock before the plastic surgeon from Austin and today. Yes, it was. I've seen some of her videos, and I know she had to do a GoFundMe. And I understand. I'm not in any way diminishing the pain that she went through, the suffering that she went through, and it is terrible for sure. However, if I was her, I would almost be gleeful and giddy every morning when I get up and I go look to see that United Healthcare stock is down, 65% on the year? I mean, it's Rite Aid level collapse. And I know people are talking about it's going to bounce back, and it is possible that it could bounce back because smart money's piling into it. I actually think probably long-term United Healthcare is done, kind of Walgreens-esque. They had major systemic problems. They are going to have to pay a huge fine, and they just completely mishandled one physician from Austin, and it drove a story. And she's not the only reason, but she is one of the most visible reasons that stock has imploded. And I point that out to say to physicians, you do not understand your power. You get stuck in these micro narratives of, the zip code that you're in and other people are staying at the country club or at church or where, whatever social circles you're in. And you don't want to be, the outcast. You don't want to be the pariah. You certainly don't have to pay lawyers. People are afraid of lawyers. But I'm here to tell you there's nothing to be afraid of. And there may be some interim financial pain. There may be a few sleepless nights, but you have extraordinary power on your own. And it is exponential if you will work in groups.
So okay, let me ask you this, like, more tactical. I mean, how much a pathologist makes, how much an early career, a hospitalist makes. How much of a financial buffer, like a living expenses, should you save up if you plan on writing content or starting a Substack where you talk about, obviously while respecting HIPAA,
Yeah.
by talking about these stories that happen behind the curtain?
Well, I always tell physicians particularly, I think it's smart to have 180 days cash on hand. And usually that takes, it depends on how you save. And I'm not a Dave Ramseyite. I'm not knocking him. That's not my flair. So, typically that could be, 2 to 3 years to build that nest egg. But I think you should probably have 180 days cash on hand. And the reason I always say that is because if you are going to transition to a new system or something goes wrong, you got to go to a new hospital. It takes about 180 days to get in network with a payer and to get your medical staff privileges done correctly. And, these things can drag on for sure. But, if you're on top of it and everything's going right, it's about 180 days. So I still think that's the right, I would love for people to have more. But, especially in the current market, I think 180 days is even a challenge. But having that much cash on hand, that gives you the flexibility to do other things, to take other ventures. And you want to have multiple streams of income. You'll have multiple, the MSI. You will have a variety of MSIs.
Okay, cool.
Multiple streams of income.
Multiple, okay, yeah. So, basically giving yourself a cushion. Now, so that concept of having cash on hand, it ties into something else I wanted to talk to you about. And we touched on the idea of how prohibitively expensive education is. And, okay, well, cash on hand, you hit the ground as a family medicine doc, working for a health system. They got you at like $220 a year, plus benefits. But then now you got all these loans. That puts you in a tough spot. It's easy for me to say this because Uncle Sam paid my tuition. So I got out of there. It took 5 years of my life, but I enjoyed it. And now I'm debt free. For a lot of these young kids that went into debt, which I would discourage anyone from doing this line of work. You think they should wait and kind of lay low until those are paid off, or would everything have passed them by the time they pay that off? I just don't imagine paying $500,000.
I know it's an obscene amount of debt. I think you should be shrewd about your. Remember that hospitals and health systems need you, so. I would go in with that leverage that I want to be paid off very, very quickly if they're going to do a loan repayment. But student loan debt does not particularly concern me. It could affect your debt to income. It just depends on what your next steps are. What are you going to do next? There are many banks in the United States who bank physicians who know what it's like. So if you want to start a clinic in the Pacific Northwest, and that's Washington Trust. That's that physicians started that. If you're in Louisiana, you want to go to Red River Bank. Orthopedic surgeons started that bank. Go to places that bank physicians. They're even kind of advertised physician banks today. So if you're going to have a physician-led enterprise, they are high cash flow. They are high EBITDA. They trade at a high margin. Even though that may be, as we kind of come into economic collapse, which we should be coming into in the fall, that probably, that will be temporarily down, but they swing right back up. And so, um, you know, I, I would not lose sleep over debt. I would look at it like a mortgage or anything else. And just pay whatever you need to pay monthly. Don't feel trapped by it. I wouldn't feel trapped by it at all. There are multiple ways to rid yourself of that. Ultimately, it's going to be by having a high margin physician owned enterprise, whether that is a clinic, an ambulatory surgery center, a physician hospital, doing direct care, whatever that's going to be, but having a high margin enterprise that you can control is going to be the quickest way to get out of debt.
Okay. Now, so I want to segue into a concept that I saw one of your posts about a week ago. I know exactly what you're talking about. And so the cost of education now, very different from the cost of education that the baby boomers inherited. The cost of living right now is very different in the 1970s that the baby boomers experienced. The cost of a home is very different now than it was in the 1970s. So how did the boomers steal the American dream from the younger generations to include the younger generation of physicians?
It's I think about that a lot because I think it is so unique in that kind of generation, that cycle. It is I'm part of a micro generation. I'm 40. I'll turn 44 next week. And so I'm part of the Oregon Trail generation. People call it centennials. If you're born between really 81 to 89 is the bell of that distribution, but some people will go out, say, as far as 79 to 91. But it's the 80s. It's 80 to 90. It's a micro generation. We have another micro generation that was born in 2010. And I guess it depends on how much you follow Strauss-Howe's, theory on generations or any of the other cyclical theories. Boomers are very interested. They're very, very interesting to me. They have high narcissistic traits. You've ever met somebody from Generation X? They are wholly fucked up. And the reason is because their parents are boomers. These Generation X has almost 4 times the rate of attempted suicide than any other generation. They have it's something like 2.5, 2.6x the incidence of substance use disorder. These, boomers are, and they're also just insufferable. The personality type is just insufferable to be around because of that high narcissistic trait that they got. And so, I don't know. It comes from being a weak generation, and their parents were part of the greatest generation who sacrificed a lot for these people to basically become parasitic, and that's what they did. They do not know struggle, and they come from this place of bacchanal and hedonism of the late 50s and 60s. And very self-centered. And you see that downstream in their life, in their everyday life, in their marriages, in their kids, in their work. And I'm of course, I'm not painting with a broad brush. We're talking about individuals here. There are good boomers, but as a whole, it is a very toxic generation. And, it is very me-centered. Boomers are the reason we have private equity so invested in healthcare. They wanted to get out, and they didn't care what the younger partner saying.
Exactly. That's what I'm talking about, man. Like, gosh, I saw this happen all around us. So earlier we were talking about Tyler, Texas, or no, that was overlapping, but these private equity practices in my industry, they're all run by retired. So the boomers didn't think about us, and they're like, well, hey, maybe we should keep this game going, give the younger generation a chance to buy in. No, they just sold to private equity, and that's what's degrading the practice of medicine and driving it into the ground.
No, absolutely. Well, you can see this also comes up. Remember, when I talk about physician-led enterprises, I tell everybody this: the number one threat to physician-led enterprise is never external, ever. It's never external. It's always internal. And it's always the physicians within the group. You could have Class C shares or Class B shares where these are non-physician owners, but they're never the problem. Problem is physicians. And it is particularly a problem whenever you have older practices that the physicians have the majority of the equity and they're trying to get young people in. And when they do, they expect these young people to do all the production and for the physicians to make all of the distribution. And that will work while these young doctors are young, dumb, and full of, excitement and vigor. But in about 5 years, these guys are tired and their kids are starting kindergarten and sometimes starting middle school, and they want to have a little work-life balance. The rupture starts happening. And that's where you see, splintering of groups, splintering of hospitals, splintering of surgery centers. It's because the boomers were immovable. And they have ruined a number of physician-led enterprises. And what happens is boomers think it's just going to go on forever. You'll always be sitting in high cotton. And then they hire somebody like me, and I'm like, no, it's not. Everything is cyclical. You've got to get out of the enterprise hopefully within 10 years, but definitely within 20 years. Just like Bezos says, when they ask me about Amazon's going to die, just like Sears, just like Rite Aid, just like Pan Am. Every business has a life cycle. And a physician's life cycle, think about your hands. Your hands are good for about 20 to 25 years. When the life insurance knows this very, very well. And so you want to get out in the prime of the cycle around year 10, earlier if you can, but definitely before year 50, and certainly not after year 20. And boomers saw it as just, we're going to hold on to it. I've made all this mailbox money. I can't tell you, I've got three clients. One, we've had to place the surgery center into bankruptcy. And it's because not all the partners could see the vision, and they kept it for so long, where, there was a lot of deferred maintenance on the building and, some other kind of issues that comes with long cycle businesses, and nobody wants to buy it. And you've run off every young physician. They're all gone. So now it's just 70 and 75-year-olds. That doesn't work. The numbers don't work. It's not actuarially sound for me to purchase. And so you see that it's not uncommon in that boomer generation. So they've been wrong.
What about the housing influence, right? So how is it possible that they suppressed interest rates for decades, inflating the prices of assets that they had the ability to own, and the generation now can't buy a house?
Exactly.
Kids can't buy a house at age 25 like their boomer parent, and somehow they're lazy and they're not resourceful. It's just like, if you're coming out of college making maybe $90,000, $70,000, how are you going to buy an $800,000 house? I mean, in a lot of major cities, you cannot, at least in Dallas. In Dallas, there's nothing under $1 million.
Right. It's not possible. And that's what's really, new physicians coming right out of residency. We used to talk about this in hospitals all the time. What does a physician want? They need, a 4,000 square foot house, maybe a 5,000 square foot house if they're an orthopedic surgeon or a neurosurgeon. And they want 2 cars, and one of them's an SUV, and one of them's a Mercedes Benz, and they want a dog and a white picket fence and 2.5 kids. And that is, the physician wants to be a member of the local country club, and physicians have a very pro forma life, and they have it's almost rigid, what they have to, how they are satisfied. Today, that's impossible. It's not possible. You can't come out with $500,000 in debt. You can't buy a Honda. I mean, it doesn't exist. It can't be done. And so it's another reason that physicians are trapped, and hospitals know it. And so they offer sign-on bonuses, and they, offer these flexible RVU payments and things like that. But it's just enough for you to have a taste, and that keeps you locked because you think you never can do it on your own. And it's gotten worse and worse and worse. And these new crops of physicians that are coming out, they have in their mind, I'm going to have the 5,000, especially if they grew up in a physician family. If they grew up and their parents were physicians, they are in for a very painful, rude awakening, where they are basically, for all intents and purposes, a factory worker. You get up from the apartment, maybe you have a stuffed animal, and you get on the streetcar here in New Orleans, and you go to the hospital, you clock in, you work your 12, and you clock out. And that is what physicians are faced with today. Again, we're kind of at critical mass right now. So that's another thing that's changing this, and physicians are looking for alternate. A lot of physicians are leaving. Just I've mentioned nurses earlier. You cannot find a nurse over 50 who's worked 20 years in the industry. That's like a leprechaun riding a unicorn. And physicians are the same right now. It is starting to get very, very scary, especially in urban areas with primary care. Physicians are disappearing, and no one can find them. And it's because they're going into other industries, or they're focused on trading. Again, they're looking for high payouts very quickly because of their debt burden, but they're leaving medicine. And so it's real scary. I mean, there's a lie that's going on against physicians right now, but the good news is it's critical mass, and it's changing the way even physicians look at this. They're starting to ask questions where 10 years ago, a physician would never question a hospital CEO. They thought they were God. You lock that boat. You can't talk to the, chief nursing officer. Today, that, of course, to be mocked. Can you imagine thinking you were beneath the chief nursing officer or some infection preventionist who took a little online course? Of course not. We always knew.
But it's like the more acronyms they have, I found this pattern. The more acronyms they have after their email signature, like the more useless.
Absolutely right.
That's like a general rule of thumb. Okay. Look, this is my philosophy, and I'll bounce it off of you. Is that, I did grow up in a physician household, also an immigrant house.
Yeah.
And my parents taught me about negotiation at a very early age. And, the person who controls the time has the upper hand.
Right.
And the person who can walk away also has the upper hand. And so my philosophy is to just lower my burn rate. I live very simply. My basic needs are met. I'm staying cash heavy so that I can say what I want. I can ask for what I want. And if they don't give it to me, it doesn't hurt me financially as much. And I have the wiggle room to just leave. And if I need 6 months to look for a better gig, then I'll do that. I'll pull my kid out of school and I'll just do that. No harm, no foul. But this is not talked about a lot amongst residents. In fact, I had colleagues that just gleefully, got on the phone. The first person that they interviewed with, they're like, "Oh my God, wow, we just clicked so well over the phone." And, they tell me their salary offer they got, and then they have to share an office with somebody. It sounds like a really shitty gig, and I don't want to make them feel bad about it, but it's like remember that movie with Vince Vaughn? He was like, it was Swingers or something. He's like, "You're so money and you don't even know how money."
Right.
And Like that's what I would tell them is just like, dude, lower your burn rate. Save up a few months worth of expenses so you can just flip them the bird and walk away.
Yes,
Well, maybe you don't have to flip them the bird, but you can walk away,
that's exactly right. And so if I was coming out or if I'm pre-med today, the first thing I would do is I would divide my career into five-year sections. And here's where I want to be. Here are my goals. Here's what, kind of net income I want to have. And here's how much I want to have in savings, all this kind of stuff. And I would have them in 5 years. And I would be saying, I'm done with medicine in 25 years from when I start. I'm going to be doing something else in retirement. I'm going to be managing my MSIs at that point, whatever those are for you. But I'm going to give this, I'm going to dedicate 25 years to it. I'm not going to die behind a desk with a white coat on. That's not happening. And so that can give people some real distinct perspective. My first 5 years, I'm head down, ass up. And it is just whatever I can do to make as much money as I can, and putting cash back. And if you're a new physician today, you definitely want to do that. Or if you're in your first 5 years today, I hope you're in a good cash position because you're about to have a once in a lifetime buying opportunity. You're about to have a 2087 or a 29-esque buying opportunity. I do not look at it as bad. You have to have corrections in the market. We're here. And it is going to be fantastic because it's going to set you up for the rest of your life. So that's number one. We'll just be thinking about, and if you don't have cash, think about, well, what can I do to get cash right now? And that's your first 5 years. And then your next two periods, your next two cycles at 5 and 5, that's a more stable time of having some work-life balance. And, it could even lead into that third year, that fourth cycle, excuse me, of just keeping everything, between the lines, developing your MSIs, whatever that is. If people are into real estate, some people are into other businesses, whatever that looks like for you, expanding your own medical empire, however that looks. And that fifth is the cleanup, wind down. If, during that period, you hopefully have a profitable business and you're selling it at that point, either to my preference to people that are younger than you in the same industry, but certainly private equity, a venture, or health systems or payers. Those are all buyers on the medical side of things. So, I'll look at it in that kind of framework. And that way you can see this as not a switch, where it's on and off, but it's a kind of a knob where you dial things up and dial things down as you need to. And it's much healthier approach to medicine and to the career itself.
Very eloquently said. Well, we kind of run the gamut, man. That was a really productive talk. I think, closing on this point of optimism for the future and buying opportunities, I would triple down on that there's going to be a lot of opportunities over the next few years to carve out a little bit of land for yourself wherever you live. If you're patient, the future looks bright. It can't get any worse than it is now.
Yeah, it does. The numbers are in your favor, 100%. You have the leverage. You have something that everybody needs. Boomers are aging. They're going to require reactive care, like no generation we've ever had. It's a high volume in the distribution, and so you're coming into high cotton. It's just going to look it could look different than what you imagine. So don't get discouraged by that. Leverage it. That's my encouragement.
Leverage the high cotton with Heath Veuleman on 3D Percuss. Thank you very much for your time, sir.
Absolutely. Thanks for having me. Appreciate it.
I hope you enjoyed this episode of 3 Deeper Cuts podcast with Heath Veuleman, Healthcare Mercenary. If you enjoyed this episode, subscribe at 3deepercuts.substack.com, YouTube, Apple Podcasts, and Spotify. I hope you have an excellent rest of your day. I'm your host, Chuck G. And until next time, be well and stay curious.